This talk is about anomalous innervation. It is intended for the clinical neurophysiology fellows at Nicklaus Children's Hospital. This talk will be conducted in a question and answer format. First question. Martin Gruber anomaly and Star Wars have in common the fulfillment of a destiny. A true, B false. The Martin Gruber anomaly is a source of confusion for the budding neurophysiologist. The Martin Gruber anomaly occurs in up to 15% of individuals, at times bilateral, and it produces strange electrodiagnostic findings. These findings are encountered during median and ulnar nerve evaluations. The confusion as to what constitutes Martin Gruber anomaly can be wiped out if we remember that in reality, Martin Gruber anomaly, as it relates to the hand, is about the ulnar nerve fibers for the abductor digiti minimi, for the first dorsal interosseous, and for the adductor pollicis, fulfilling their destiny after having taken a detour. Their destiny is entering the hand with their peers, the other hand ulnar nerve muscle fibers. The detour is entering the wrong nerve, the median nerve, instead of the ulnar nerve at the brachial plexus to come down to the hand. So the answer to this question is true. Next question. Which of the following nerves is not involved in Martin Gruber anomaly? A. Anterior interosseous nerve. B. Posterior interosseous nerve. C. Ulnar nerve. D. Median nerve. The nerve fibers involved in Martin Gruber anomaly, the abductor digiti minimi, the first dorsal interosseous, and the adductor pollicis, must make two decisions. The first decision these fibers must make is taken at the level of the brachial plexus. When the fibers for the abductor digiti minimi, the first dorsal interosseous, and the adductor pollicis are in the medial cord. Here, these fibers decide either to take the medial branch of the medial cord, as they usually do, and go to the ulnar nerve, and in it travel distally, or from the medial cord take a different route, going to the lateral branch of the medial cord to join the median nerve, and in it to travel distally. It is when they make this later decision, which they do in about 15% of the cases, that is to go distally in the median nerve, that the seed for Martin Gruber anomaly is planted. So that was the first decision, which, as we saw, is made at the brachial plexus. Now comes the second decision. The second decision is made by these fibers at the level of the proximal forearm, in the area that I have encased in a green rectangle and now enlarged. Here, the fibers destined to innervate the abductor digiti minimi, the first dorsal interosseous, and the adductor pollicis either go to the anterior interosseous nerve as I am representing by the yellow line and indicating by the white arrow in this frame, or continue in the main trunk of the medial nerve as I am representing in this new frame by the yellow line and pointing with the white arrow. Regardless of them going to the anterior interosseous nerve or staying at the main trunk of the median nerve, these fibers must fulfill their destiny. So, if the fibers had taken the anterior interosseous nerve, they exit it and go to the ulnar nerve as I have represented by the yellow line and pointed to with a green arrow in this frame, or if they had chosen to remain in the main trunk of the median nerve, they also exit it and go to the ulnar nerve as I have represented by the yellow line and pointed to it with the green arrow in this frame. That is in the lower figure of this frame. It is actually this crossing at the forearm that bears the name of Martin-Gruber anomaly. It is important to remember that this crossing may take place as low as 8 centimeters below the medial epicondyle, or more approximately at 3 centimeters below the medial epicondyle. So the answer to this question is B. Next question. Martin-Gruber anomaly type 2 is the most frequent one encountered by clinical neurophysiologists. A true, B false. There are many classifications of Martin-Gruber anomaly. One of the anatomical classification exclusively addresses the fibers going to the hand muscles, and especially those I have mentioned before. This classification divides Martin-Gruber anomalies in 3 and labels them 1, 2, and 3 respectively. The grouping is made according to the destination of the fibers going across from the median to the ulnar nerve. In addition, when all the fibers for a given destination are involved, the letter A is added, and when only some of the fibers take the detour, the letter B is added. So, Martin-Gruber anomaly type 1A implies that all abductor deity minimi fibers are involved, which I have represented in this frame as a solid brown line in the brachial plexus. 1B implies that only some of the abductor deity minimi fibers have taken the median route. As you can see, I have represented partial misdirection as broken lines traveling in the ulnar and median nerves. Martin-Gruber type 2 involved the fibers for the first dorsal interosseous. It is the most frequent of all the Martin-Gruber anomalies. When all fibers go to the median nerve, as I have been indicated in these frames, it is labeled type 2A. When only some of the fibers take the detour, it is classified as type 2B. If all adductor polycyst fibers go to the median nerve, we talk about Martin-Gruber type 3A. And if only some of the fibers going to this muscle takes the detour at the brachial plexus, then we refer to it as type 3B. So the answer to this question is A. Next question. The distinction between all fibers going to the median nerve and only some fibers going to the median nerve is important for electrodiagnostic testing. A true, B false. Do not worry. The distinction between some and all fibers going to the median nerve do not make a big difference for neurodiagnosticians. So the answer to this question is B. Next question. Martin-Gruber anomaly to a thenar muscle may be suspected during routine median nerve testing. A true, B false. This chart summarizes most of the situations encountered in clinical practice during median motor nerve conduction testing that raises the suspicion of a Martin-Gruber anomaly based on amplitude comparison between median nerve potentials generated at the wrist and at the antecubital region. I will address each of these situations separately, so just follow along and do not try to read the whole chart at this point. The presence of Martin-Gruber anomaly based on amplitude of the proximal and distal generated potentials should be suspected following a routine median motor nerve conduction testing in 4 situations. The first situation arises if the proximal, that is the antecubital fossa generated potential, and the distal, which is the wrist generated potential amplitudes, are in the normal range, but a positive dip is present at the onset of the negative wave. The normal range of accepted amplitude differences between proximal and distal potentials vary according to different authors. Some authors consider a drop bigger than 10% abnormal, while others have raised the limits to consider only the possibility of conduction block if the difference is more than 20% and no more than 15% increase in duration. The other important feature of this example is the presence of a dip. The importance of the dip cannot be overemphasized. A positive dip preceding the negative compound motor action potential present following stimulation of any motor nerve results from the simultaneous arrival of median thenar nerve fibers and ulnar fibers to the FDI, the adductor pollicis, and the deep head of the flexor pollicis brevis, or all of them in the case of the median nerve. The arrival of the later electrical impulse and activation of previously mentioned muscle fibers occur far from the intended motor point of the abductor pollicis brevis. In the next frame, I will illustrate these points and hopefully they will become clear. Here, the E1 during median nerve conduction study is placed on the thenar region above the motor point of the abductor pollicis brevis. This electrode location coincides with the epicenter of the volume conducted electrical activity provoked by the activation of the median nerve innervated hand muscle. I have presented these fields as concentric red circles, as you can see. Please notice that the size of the circles that correlates with the size of the field and the positions of the fields. Here, the arrow points to the site of distal stimulation, and here, the site of proximal stimulation, thus producing the typical potential with sharp deviation from the baseline. I have now introduced a diagram of Martin-Gruber anomaly involving the first dorsal interosseous and the adductor digiti minimi. The epicenter of the volume conduction with distal stimulation of the median nerve occurs under the recording electrode, since here only median fibers are stimulated, because the fibers coming through the Martin-Gruber anomaly are not present distally. Thus, stimulation of the distal portion of the median nerve will produce a sharp rise potential. But with proximal stimulation, since not only median nerve fibers but also fibers traveling in the Martin-Gruber anomaly are stimulated, the epicenter of the volume conduction is not centered in the E1 electrode as it was when the stimulation was done distally in the median nerve. So proximal stimulation will produce a field that does not have the epicenter at the thenar electrode. Thus, the potential that it will produce will have a dip prior to the negative wave, as it usually happens whenever E1 electrode is not over the motor point of a muscle that is being stimulated. The second situation that should make us think of the possibility of Martin-Gruber anomaly during median motor nerve conduction is when the potential generated by proximal stimulation is bigger than the potential generated by distal stimulation. That is, if the antecubital generated potential is bigger than the wrist generated potential. In this frame, I have introduced a control just to show how things normally are. As you can see, they are the same as the one we discussed a few minutes ago for normalcy. In addition, in this new frame, I have added the schematic representation of Martin-Gruber anomaly involving the thenar muscles. The electrical field created by the volume conduction following distal and proximal stimulations will be different, and as you can see, the potentials that they will produce will vary. Notice here that the electrical field generated following proximal stimulation is larger than the one produced with distal stimulation. Now notice the size of the proximally generated potential. It is also larger than the distal generated potential, as it would be expected. This amplitude difference occurs because the potential generated following proximal stimulation represents the summation of the median thenar muscle activation and the activation of the ulnar muscle activation that travel through the Martin-Gruber anomaly, whereas the potential generated following wrist stimulation only represents the activation of the thenar median nerve muscles. In this frame, I have represented the individual potentials in their respective color, as you can see, so you can see the contribution of each of these fibers to the final potential. The third situation during median motor nerve testing that Martin-Gruber anomaly should be considered is when the proximal potential is smaller than the distal potential and there is a slow conduction across the wrist. I have reintroduced the control on the left side of the frame as I have done before, and now the Marcus-Gruber anomaly representation with the respective fields created by distal and proximal stimulation. The one on top, as you can see, is the result of distal stimulation. The one below is produced by proximal stimulation. Notice that the one below is smaller than the one above. I have now added two little clocks with a certain time as indicated by the long handle. The long handle in each clock indicates the latency to each potential. Time, as you know, is a factor in the size and configuration of potentials because two perfectly coinciding electrical fields add up to a larger potential than each of them individually, whereas asynchronous fields cancel each other, leading to a smaller potential than each of them individually. Notice that the clock above, corresponding to the latency of the distal stimulation, indicates a longer latency than the one below. This is so because all fibers stimulated by the distal stimulation go through the carpal tunnel, which is the source of the slowing. Whereas with proximal median nerve stimulation, the fibers going through the Martin-Gruber anomaly, ending up in the thenar eminence, they do not go through the carpal tunnel, thus are not subject to entrapment. I have now introduced the waves corresponding to this situation. As you can see by looking at the controls to gain proportion, a wave arising from proximal stimulation is shorter than the one from distal stimulation, as they normally are, but the latency of both is increased. In this new frame, you can see the contribution of the fibers going through the Martin-Gruber anomaly in yellow and the contribution of the median nerve fibers in aqua. The fourth situation that should make you think of the possibility of Martin-Gruber anomaly is the occurrence of proximal stimulation potential before the distal stimulation potential. Notice that the latency following distal stimulation is way longer than the latency following proximal stimulation. This occurs in cases of extreme slowing at the carpal tunnel. In such cases, the proximal stimulated fibers going from the median to the ulnar nerve in the Martin-Gruber anomaly bypass the carpal tunnel and therefore arrive at the thenar eminence at the appropriate time, but the distal stimulated median fibers would be greatly delayed by the carpal tunnel entrapment. Notice their color match representation in this frame. I have reintroduced the figure about amplitude comparison that you initially saw to point out one more feature in it. And that feature is that whenever during median nerve conduction studies you consider the possibility of Martin-Gruber anomaly, you should test ulnar nerve conduction to the thenar eminence. This maneuver will often confirm or negate the presence of Martin-Gruber anomaly. So the answer to this question is A. Next question. When Martin-Gruber anomaly to a thenar muscle is suspected during routine median nerve testing, leaving the electrodes in place and stimulating the ulnar nerve at the wrist and below the elbow often resolve the issue. A true, B false. When Martin-Gruber anomaly carrying fibers to the thenar muscle is suspected during routine median nerve testing, we can do one of two things. One would be the one that we already mentioned, which is to leave the electrodes in place, that is on the thenar eminence, and stimulate the ulnar nerve distally and proximally. This way we'll be recording from the thenar eminence while the ulnar stimulation is regularly not done. If such a test is done in a person without Martin-Gruber anomaly to the thenar muscles, we will get an unusual waveform since E1 is not in the epicenter of the field. This field will be very similar following distal and proximal stimulations, except that the potential recorder after proximal stimulation will have a longer latency, and it will also be perhaps slightly longer because of dispersion. The same study done in patients with Martin-Gruber anomaly, which I am representing now on the right side of your screen, that is, this test performed in patients carrying fiber to the thenar muscle, will look different depending on the site of stimulation. Distal stimulation will show the same type of potential we saw in control, since at this location all fibers going to the thenar region have been incorporated to the ulnar nerve. But proximal stimulation will show no potential. This is so because at the upper forearm, the nerve fibers for the ulnar thenar muscles have not yet joined the ulnar nerve. The second thing we can do when Martin-Gruber anomaly to the thenar muscle is suspected during routine median nerve testing is to change the electrodes to record FDI and do ulnar distal and proximal stimulations. In control, we will get the usual looking potentials with proximal longer latency and a drop in amplitude not exceeding 10% as expected. In people with Martin-Gruber anomaly to the thenar muscles, distal stimulation will produce a normal potential, the same as in control, but proximal stimulation will show no potential, for the same reason that we explained just a few seconds ago. So both possible ways to check the possibility of Martin-Gruber anomaly after it being suspected during median nerve study is to see if the first dorsal interosseous or any of the ulnar innervated thenar muscles are traveling in the upper forearm. In individuals without Martin-Gruber anomaly, there will be fibers traveling in it. In patients with Martin-Gruber anomaly, they will not be traveling in the ulnar nerve at that point, that is proximally. So the answer to this question is A. Next question. Martin-Gruber anomaly to the adductor digiti minimi may be suspected during routine median nerve testing. A true, B false. As you can see in this frame, I have represented median motor nerve distal and proximal stimulations. The epicenter of the field produced by this stimulation in the presence of Martin-Gruber anomaly carrying fibers to the abductor digiti minimi and their corresponding waves. The wave are now indicated by the arrow. The wave now indicated by the arrow corresponds to the potential obtained after distal stimulation. And the one I am indicating now to the one obtained following proximal stimulation. On the other side of the frame, the diagram represents Martin-Gruber anomaly carrying fibers for the abductor deity minimi. Notice that the wave produced by distal and proximal stimulation look about the same as control. Hence, although we talk about Martin-Gruber anomaly as being one entity from the point of view of electrodiagnostic testing, it looks like basically two different entities. One when the fibers go to the thenar eminence, and the other when the fibers go to the hypothenar eminence. So the answer to this question is B. Next question. Martin-Gruber anomaly to abductor deity minimi may be suspected during routine ulnar nerve testing. A true, B false. The figure presented in this frame represents normal ulnar nerve responses obtained following distal and proximal stimulations. Recording being done from the abductor deity minimi. I have now introduced a representation of Martin-Gruber anomaly carrying abductor deity minimi fibers. With distal stimulation, the potential is the same as in control. With proximal stimulation, the potential will be flat or minimally raised, since the maximal contributor to this potential, the fibers for the abductor deity quinti, will not be stimulated during proximal ulnar stimulation. So the answer to this question is A. Next question. Martin-Gruber anomaly to a thenar muscle may be suspected during ulnar nerve testing to FDI. A true, B false. Please take a few seconds to look at this frame. On the left side of the screen, you have the control for ulnar to FDI testing, and on the right side, the representation of ulnar nerve testing to FDI in patients with Martin-Gruber anomaly carrying the fibers to this muscle. The important thing to remember is that proximal stimulation will not show a potential because the fibers being carried by the Martin-Gruber anomaly have not yet crossed back to the ulnar nerve at the proximal site of stimulation. Hence, they will not be present at the proximal site, but will be stimulated at the distal site when we are performing ulnar testing. So the answer to this question is true. Next question. A suspected Martin-Gruber anomaly carrying fibers to the thenar muscles following ulnar motor nerve testing may be confirmed by median nerve stimulation while leaving the recording electrodes at the FDI site. A true, B false. On your left, you can see a cartoonish representation of the wave obtained from distal and proximal ulnar nerve stimulation in the presence of Marcus-Gruber anomaly carrying FDI fibers. Notice that no wave is present following proximal stimulation. On your right, I have included the same situation as it relates to the anomaly, but now stimulating the median nerve proximally. Notice the field represented by the red concentric lines. I have now introduced the same figure, but showing proximal stimulation. Notice that the field is bigger because with proximal stimulation of the median nerve, the fibers to the FDI destined to cross at the Martin-Gruber anomaly have not done so yet. This will be reflected by the larger proximal than distal potentials with median stimulation? So the answer to this question is true. Next question. Martin-Gruber anomaly may produce nerve conduction study results with characteristics of ulnar elbow neuropathy. A true, B false. During ulnar nerve testing, Martin-Gruber anomaly, when involving the abductor digiti minimi or the first dorsal interosseous, may produce, as we have seen before, characteristic electrical findings, most of the time suggestive of conduction block at the level of the forearm, because the amplitude of the distal generated potential from the wrist stimulation is bigger than the amplitude of the below the elbow generated potential. So, in most instances, the situation depicted in this frame will occur. The wrist elicited potential is normal, and the below the elbow and above the elbow potentials are absent or greatly diminished. These findings reflect that the fibers of these muscles are in the ulnar nerve at the wrist and not at the other two sites. This will be so because the crossing of the fibers of these muscles take place distally to the point of the below the elbow stimulation. On the other hand, if the crossing is proximal to the below the elbow stimulation, then the wrist and below the elbow stimulation will be normal, and the above the elbow stimulation will produce no or a reduced potential. This constellation of findings erroneously would suggest an elbow conduction block. So the answer to this question is true. Next question. Which of the following conditions would you not consider in a patient with the findings above? A. Martin-Gruber anomaly to FDI. B. Excessive ulnar stimulation at the wrist. C. Submaximal ulnar stimulation below the elbow. D. Ulnar conduction block between the wrist and elbow. A distal ulnar motor potential 20% larger and less than 15% longer than a proximal potential would suggest conduction block between the two stimulated sites, in this case in the forearm. As you probably know, in Preston and Shapiro's book, the recommendation is that if a drop is more than 10%, the median nerve should be studied because of the possibility of Martin-Gruber anomaly or a conduction block. Be it as it may, a significant drop requires an explanation. One possible explanation for the waves in this question is the presence of a Martin-Gruber anomaly to the abductor digiti minimi, since we are recording from the hypothenar region. But in addition to Martin-Gruber anomaly to the abductor digiti minimi, we must consider other possibilities such as excessive ulnar stimulation at the wrist, submaximal ulnar stimulation below the elbow, and, as we initially stated, an ulnar conduction block between the wrist and the elbow. So the answer to this question is A. Next question. Which of the following conditions would you consider? A. Martin-Gruber anomaly to ADQ. B. Excessive ulnar stimulation at the wrist. B. Submaximal ulnar stimulation below the elbow. D. Ulnar conduction block between the wrist and the elbow. First, let's consider the possibility of Martin-Gruber anomaly to the abductor digiti quinti or abductor digiti minimi. More than 10% drop between distal to proximal ulnar potential requires an explanation. But as the question stands, we do not know if the ulnar recording was from the hypothenar or from the FDI region. We know that distal median stimulation show no potential, which exclude the possibility of FDI as a possible recording site, since with distal medial nerve stimulation and recording from the FDI site, at least a positive little potential will be recorded. So it is likely we are recording from electrodes located in the hypothenar region. Now, proximal median stimulation reveal a negative potential, suggesting that a hypothenar muscle is getting activated and that the patient has a Martin-Gruber anomaly to the abductor digiti minimi. Notice the amplitude of each of the potentials. The arrows are color matched with the contribution of each nerve fiber. The amplitude of the potential following distal ulnar stimulation is made up of fibers that have traveled in the ulnar nerve from its birth at the brachial plexus and from fibers that have joined the ulnar nerve after they cross in the anomaly. The amplitude of the potential following proximal stimulation is made up of ulnar fibers without the fibers that have crossed in the anomaly, since at this point they have not yet crossed. The amplitude of the potential following proximal median nerve stimulation is made up of the fibers for the abductor digiti minimi that have yet not crossed in the anomaly. If we add the proximal recorded potential from the ulnar nerve and the median nerve potential from the proximal site stimulation, we will have the amplitude of the potential generated by distal ulnar stimulation, as you can see here. These findings establishes the presence of Martin-Gruber anomaly to the abductor digiti minimi. So the answer to this question is A. Next question. When considering the possibility that excessive proximal stimulation of the median nerve is exciting the ulnar nerve, you should stimulate between them. A true, B false. If presented with this situation and you desire further proof that the potential obtained at the hypothenar region following proximal median nerve stimulation is not due to excessive stimulation and unintended excitation of the ulnar nerve, the best thing to do is to stimulate between the nerves. If no potential is recorded in the hypothenar electrode, contamination due to excessive stimulation and unintended stimulation of the ulnar nerve is unlikely. If, on the other hand, you record a potential, especially if it is bigger than the one you previously recorded after median nerve stimulation, that is after proximal median nerve stimulation, there is a strong possibility that the potential being recorded is due to ulnar contamination due to excessive median nerve stimulation. So the answer to this question is A. Next question. The pattern above excludes the possibility of Martin-Gruber involving the abductor digiti quinti or abductor digiti minimi. A true, B false. The possible explanation for this pattern, excluding technical issues, are Martin-Gruber anomaly or forearm conduction block. The presence of a positive potential recorded from the hypothenar region following median nerve distal stimulation and no potential following proximal median nerve stimulation indicates that the median recorded potential is likely to be due to volume conduction from the median nerve stimulated muscles in the thenar region, and the absence of potential following proximal median nerve stimulation indicates that the fibers of the abductor digiti minimi were not present in the proximal median region. So the answer to this question is A. Next question. The possibility of Martin-Gruber anomaly is excluded if the below elbow ulnar motor nerve conduction study is normal. A true, B false. Remember that although in Martin-Gruber anomaly the crossover to the ulnar nerve usually takes place 8 centimeters below the medial epicondyle, and in such cases ulnar nerve testing would suggest a block between the wrist and the elbow, but not an ulnar nerve conduction block at the elbow. But when the crossing takes place more proximally, as sometimes it does, let's say 3 centimeters below the elbow, electrodiagnostic testing may resemble elbow conduction block. So the answer to this question is B. Please take a few minutes to look at this frame and try to answer the question below. These findings suggest severe carpal tunnel syndrome and Martin-Gruber anomaly to adductor policies. A true, B false. In the absence of technical issues, the ulnar nerve finding suggests Martin-Gruber anomaly or forearm conduction block. The fact that the median nerve potential after wrist stimulation is more delayed than the potential following median nerve proximal stimulation is evidence of severe wrist entrapment. The earlier occurrence of thenar potential with proximal median nerve stimulation indicates that some fibers going to the thenar eminence have arrived there before others, and those fibers that have arrived there before are those that went across the Martin-Gruber anomaly, that is, those for the adductor pollicis and those for the first dorsal interosseous. So the answer to this question is A. Next question. Rich-Kenyu anomaly is defined as a connection between the recurrent branch of the median nerve and the deep branch of the ulnar nerve in the hand. A true, B false. The brachial plexus here presented is the first of several elements we need to take into account to understand Rich-Kenyu anomaly innervation in relation to other common and relatively rare anomalies of hand innervation. The other elements are the arm, the forearm, and the hand. And in the hand, those muscles innervated by the median nerve and muscles innervated by the ulnar nerve are represented. In most people, to which we refer as normal, the median nerve forms by the union of the lateral branch of the medial cord and the medial branch of the lateral cord. The median nerve advances distally in the arm and the forearm to reach the hand and innervate a set of muscles that we will refer to as the median nerve innervated muscles. The ulnar nerve is formed by the extension of the medial branch of the medial cord. The ulnar nerve advances distally in the arm and the forearm to innervate another set of muscles in the hand that we're going to refer to as the ulnar innervated muscles of the hand. I have now introduced a simplified illustration of Martin-Gruber anomaly. In Martin-Gruber anomaly, as you know, and is shown in this figure by the white line, some nerve fibers destined to enter the hand with the ulnar nerve through the Guyon's canal mistakenly go in the lateral branch of the medial cord to the median nerve in the arm, and at the level of the forearm they cross over to the ulnar nerve. This innervation pattern corresponds to Martin-Gruber anomaly. Another anomaly we have to consider when doing nerve conduction studies of the upper arm is Marinazzi. Here, fibers destined to enter the hand in the median nerve through the carpal tunnel canal make their way and end up in the medial branch of the medial cord, ultimately reaching the ulnar nerve and traveling in it downwards. And at the level of the forearm they cross to the median nerve, thus innervating the median nerve muscles appropriately after traveling inappropriately with the ulnar nerve until reaching the forearm. The next anomaly is Rich-Canu anomaly. This anomaly is defined as a connection between the recurrent branch of the median nerve and the deep branch of the ulnar nerve in the hand. The fibers in this connection have been described as median fibers that mistakenly travel down in the ulnar nerve returning to the median nerve by the anomalous hand connection, or ulnar fiber that mistakenly travel down in the median nerve returning to the ulnar nerve by the anomalous hand connection. The last arm motor innervation anomaly I will mention is the ulnar hand. In this anomaly, all the fibers that would normally travel in the median nerve take the ulnar nerve down from the brachial plexus and stay in the ulnar nerve until they reach the hand. Thus, all hand muscles are innervated by the ulnar nerve. All these anomalies may produce peculiar patterns of neurodiagnostic findings that neurophysiologists must be aware of. So the answer to this question is A. Next question. Berrettini anomaly precludes the use of the ring finger as a sole indicator of carpal tunnel pathology. A true, B false. This frame shows the usual innervation of the hand. That is the usual sensory innervation of the hand. I have in this new frame labeled the median nerve branches involving in-hand innervations. Notice that the palmar cutaneous branch leaves the median nerve prior to the median nerve reaching the wrist. I have now introduced the ulnar branches. Also notice that the palmar branch of the ulnar nerve leaves the ulnar nerve before the wrist, just as the palmar cutaneous branch of the median nerve did. Also notice that the radial side of the ring finger is innervated by one of the digital branches of the median nerve. In the Berrettini anomaly, there is a connection of the ulnar digital nerve located between the fourth and the fifth digit to the median digital nerve located between the third and the fourth finger. And these aberrant fibers become the sensory fibers for the radial side of the ring finger. Thus, the whole of the ring finger is innervated by the ulnar nerve, and in such cases, median wrist to ring finger sensory testing would mistakenly be interpreted as median nerve sensory axonal loss due to carpal tunnel syndrome. So the answer to this question is A. Next question. Which is the most common anomalous innervation in the lower extremity? A. Peroneal posterior tibial nerve communication. B. Accessory peroneal nerve. C. Innervation of the extensor digitorum brevis by the posterior tibial nerve. D. Innervation of the extensor digitorum brevis by the sural nerve. This figure shows the usual innervation of the anterior lower leg and foot. Extensor digitorum brevis recording following peroneal nerve testing at the ankle below the fibular head and above the fibular head produces stereotypic findings, with the potential obtained following ankle stimulation being the tallest. If this is not the case, that is, if the ankle potential is not the tallest, the area behind the external malleolus should be stimulated. In patients with accessory peroneal nerve, a large potential will arise. This will document the presence of an accessory peroneal nerve, which is the most common cause of anomalous innervation in the lower extremity. So the answer to this question is B. Next question. Ulnar nerve conduction study is normal, except for absence of ulnar sensory nerve potential, wrist to fifth digit. Your conclusion is ulnar axonal neuropathy. A. True. B. False. If the situation depicted in this frame and in the questions occurs, that is, if ulnar stimulation at the wrist produces no sensory potential recorded at the small finger, contrary to what usually happens in normal situations, that is, that a potential does appear, the likelihood explanation is that the whole of the dorsal of the hand is innervated by the radial nerve. Then a stimulation of the radial cutaneous nerve will produce a normal potential recorded from the digiti minimi. So the answer to this question is B. Thank you very much for your attention.